Good afternoon, everyone. We'll start our session. This is anticipated to be a really interesting session. We have an outstanding panel. There are going to be 6 talks in this session. The first 5 will be about 12 minutes each, and the last one will be 15 minutes. We would want you to hold your questions till the end so that we can have an extended question and answer session at the end. I'm Dheeraj Yadav from the University of Pittsburgh, and my co-moderator is Dr. Julia McNabb-Balter from Brigham and Women's Hospital, who's going to introduce our first speaker.
Thank you. So our first speaker is Anna Phillips from University of Pittsburgh, and she will present on the medical management. Has there been any progress?
Thank you and welcome this afternoon. First, thank you, Julia and Dheeraj, for the wonderful introduction and to the organizers for the opportunity to present this afternoon. I'm certainly quite honored by the distinguished company that I find myself in, and I look forward to the rest of these talks this afternoon. I have no financial disclosures to make. And so as the opening talk of this session, I wanted to give just a very bit of background and say that I think we have reason to be cautiously optimistic that we have made some progress in medical management of painful chronic pancreatitis. And so in this arena, I'm going to discuss a few updates in pain assessment, treatment of the disease, and then in prediction of outcome to treatment, as well as a few thoughts on our future directions at this time. Pain, as many of you know, is the most disabling symptom of chronic pancreatitis and affects up to 90% of patients over the course of their disease. There are multiple mechanisms that contribute to pain in chronic pancreatitis. These treatment guidelines from some of the most incisive and thoughtful minds in our discipline show the incredible complexity, of course, of the medical management of this disease. Nonetheless, these can, of course, be simplified, and we all aim to do that as we try to advance treatments in the medical realm of painful chronic pancreatitis treatment. Now, traditionally, pain patterns in chronic pancreatitis have fallen into 2 categories. Type A pain is thought to be kind of intermittent attacks of pain with pain-free intervals, and a type B pain is a more constant pain with exacerbations of pain. But what we've seen in more recent years, and from this elegant study by the Dutch Pancreatitis Study Group, is that actually pain patterns are constantly changing in chronic pancreatitis. In this study, looking at over 1,100 definite chronic pancreatitis patients, 61% of their cohort had at least one change in their pain profile over a follow-up of 47 months, suggesting that this is an incredibly dynamic situation for patients with this disease. In recent years, we have learned a lot more about different aspects of the pain experience for our patients. This study from 2021 elucidates 5 different specific factors in their frequency in a population of patients with chronic pancreatitis. On the left-hand side, what you see are the frequency of 5 different realms: pancreatic ductal obstruction, hyperalgesia, anxiety, depression, and catastrophizing that all contribute to the pain experience. On the right-hand side, what you see is the Venn diagram of the overlap of these experiences for patients, with anxiety, depression, and catastrophizing being combined into a single category called psychologic distress. What we also had learned from this study is that there is a cumulative effect of overlapping factors in chronic pancreatitis. As this situation gets more complex for patients, it gets worse. What we saw was a linear increase in both the pain severity and pain interference, as well as a linear decrease in quality of life with the accumulation of each of these pain-related factors, again showing us that this situation gets worse as it gets more complex for patients. From this study in 2024, we learned a little bit more about psychotropic medication use in chronic pancreatitis. Many of these agents are suggested actually as adjuvant or adjunctive therapies in chronic pancreatitis, but little has been studied to understand either the frequency of their use, and very few of them have actually been tested in this disease to understand the efficacy of their utilization as adjunctive therapies. What you see just from this simple assessment of looking at the frequency of their use is that over half of patients in this US population are maintained on SSRIs and gabapentinoids. A lesser number, but still significant, are maintained on things like benzodiazepines and other antidepressants. Now, looking at the assessment of chronic pancreatitis pain, our discipline has long lacked a validated pancreas-specific tool for chronic pancreatitis pain assessment. What you see in this chart from a publication in Pancreatology in 2016, across the top are different tools that are frequently used actually to assess pain in this disease. In the left-hand column, what you see are different aspects of the pain experience in this disease. And a single quick glance at this chart shows you that none of the frequently used assessment tools assesses the disease aspects of painful chronic pancreatitis adequately. Interestingly, we also see that postprandial pain, one of the most salient features of this disease, is assessed by none of them. The comprehensive pain assessment tool has been developed since that time. And this tool has been developed and then further distilled down into a short form, a single 3-page form that takes 10 minutes for patients to fill out at the bedside. This assessment tool is pancreas-specific, and it assesses multiple aspects of the chronic pancreatitis pain experience. Not only does this tool exist in publication form and is widely available for ready use in English, but an app creation is underway for both iOS and Android platforms, and multiple translations in different languages are underway in order to be able to facilitate the widespread dissemination of its use. Now, medical management for painful chronic pancreatitis has long centered around analgesia. What you see here is a modification, of course, of the World Health Organization's pain, the stepped ladder, starting first with non-opioid analgesics, moving through mild opioids, then to more potent opioids, and then referral for surgery and other interventional procedures, which we're going to hear more about in this session. Now, there are ongoing efforts in prospective observational studies to understand more about the frequency and patterns of use of each of these agents in U.S. populations as well as others. Namely, I can say that the Consortium for the Study of Chronic Pancreatitis, Diabetes, and Pancreatic Cancer is actively working on this because baseline foundational evidence doesn't currently exist in published form about this. Now, there are treatment trials in painful chronic pancreatitis. A number of them are ongoing currently in this disease where we have no cure. Namely, I can say that there are treatment trials with lacosamide, an anti-epileptic agent, voltage-gated sodium channel inhibitor, used in conjunction with opioid therapy to try and control CP pain better. Simvastatin is being used to try and restore acinar cell homeostasis and improve patient-reported outcomes in painful chronic pancreatitis. Paracalcitol, a vitamin D analog, is being used to improve health-related quality of life in this disease. Antifibrotic agents are being tested in safety trials aimed at delaying the progression of fibrosis, and even cognitive behavioral therapy is being utilized to enhance coping mechanisms in this population. Now, none of these have been deployed regularly or in a standardized fashion in the clinical setting, but we eagerly await the product of these trials in order to understand better how these can be initiated. Now, invasive treatments are numerous for this disease, but of course, And of course, there is still much indication for these. Unfortunately, pain response rate to treatment remains not only unpredictable, but also suboptimal. I've highlighted 3 figures here from major trials in the last 2 decades, describing direct comparisons between surgical and endoscopic therapy for this disease. Now, I show these not to reopen the long-standing argument about which of these approaches is superior to the other, but rather to highlight the fact that patients in these trials have been medically optimized before being referred for intervention, and then subsequently undergone clinically indicated invasive intervention for painful chronic pancreatitis. Despite the best therapies that our field has to offer, the majority of patients still have pain at the end of these trials. This suggests actually that there are major aspects of the pain experience in this disease that we continue to miss. One of those that has been recently described in recent years is the phenomenon of central sensitization, the amplification of neural signaling within the central nervous system that elicits pain hypersensitivity. Currently, there is no clinical test available to identify this phenomenon. However, the idea is that in painful chronic pancreatitis, as in other painful conditions, we see the development of central sensitization over time, where patients who have pain may begin with normal processing of pain signals, but end up having changes in their peripheral and central nervous systems that result in widespread hyperalgesia suggestive of central sensitization, that then alter their pain response and make it very difficult to treat them with the existing therapies that we have. Pancreatic quantitative sensory testing is a technique that has been developed specifically for use in patients with chronic pancreatitis and consists of a standardized set of stimulations revealing the function of sensory nerve fibers. And the idea is that this set of tests will allow us to detect widespread hyperalgesia suggestive of the presence of central sensitization. A pilot study using this technique in the prediction of pain response to invasive treatment for painful chronic pancreatitis, recently published in Pancreas, shows that there is a higher frequency of patients with widespread hyperalgesia, suggestive of central sensitization, in the population of patients who had no or negative pain response to their invasive therapy than those who had a positive response to their invasive therapy. This suggests, indeed, that central sensitization may render patients less likely to respond to technically successful therapies that we currently have for this disease. This has evolved into an R01-sponsored clinical trial, actually, looking to test the predictive capability of this technique for pain improvement following invasive treatment for painful chronic pancreatitis. And so, in summary today, what I would say is that, again, we have reason to be optimistic at this time for the advancement of medical management of painful chronic pancreatitis. I have to applaud my colleagues every day who are making small, incremental, but important advancements in this disease. The microphone has been cut off, so I'll just talk louder. And so we are currently trying to improve the understanding of pain experience in chronic pancreatitis. The advancement and the dissemination of the COMPET-SF actually identifies an immediate opportunity for us to be able to understand more aspects, both in research settings and in clinical settings for our patients. The completion of observational studies to better assess previously unexplored aspects of the pain experience in this disease also offers us an understanding that will be able to serve us better in future years. With regard to treatments, our focus, of course, is always on a cure for this disease, even though it remains elusive at this time. The development of antifibrotic agents and the use of methods to mitigate opioid use and reduce harm in this disease also offer important opportunities. Lastly, the use of prediction tools for the outcome to invasive treatment will only help us to better optimize patient selection for those who will benefit most, and we truly hope that we can use this to our advantage. I'd like to say thank you, and thank you for your the opportunity to speak.
Our next speaker is Lauren Canna from NYU, and she will present on SWAL, patient selection, technique, and outcomes.
Thank you so much to the organizers for the opportunity to speak, and to the moderators. And it is also an honor to be on this panel, and I think we'll see a lot of overlap in our different talks. So I'm tasked with speaking about SWAL. So as we all know, pancreatic stones are made of calcium carbonate concentrations, and they're a sequela of chronic pancreatitis. The prevalence is variable, but estimated to be at least 50% in people with chronic pancreatitis. And there's sort of old data that states that the risk of developing pancreatic duct stones correlates with the length of disease, that at 5 years of disease, up to 50% of people have pancreatic duct stones, and at 10 years, nearly 100. When thinking about the way to classify pancreatic duct stones, we want to think about whether they're intraductal and whether they're in the main branch of the pancreatic duct or in a side branch, or whether they're parenchymal. We want to think about whether there's a single stone or multiple. We want to think about the location within the pancreas, whether they're in the head or the body or the tail. And especially when we're thinking about the application of SWAL, we want to think if they are radio-opaque, which is the majority of pancreatic duct stones, versus radiolucent, which become much more difficult to target with SWAL. And some stones can be mixed. We need to discuss the indications for intervention for pancreatic duct stones. We think of the stones as being a source of ductal obstruction, or they may be a sequela of ductal obstruction if there's a stricture and the stone is upstream of the stricture. Our general philosophy is that by improving pancreatic duct drainage, we allow duct decompression and a decrease in the intraductal pressure, which in some sense may be a cause of pain, although as Dr. Phillips just mentioned, the pain is multifactorial, and that's one of the reasons that relief of pancreatic duct obstruction may not relieve pain alone. And then a secondary outcome that's important to think of, and I think increasingly important, is the improvement of pancreatic function. So in general, we've thought of intervening on pancreatic duct stones in symptomatic patients, particularly pain, and this is what most studies focus on. But I think there is a role for considering whether there is a relevance of intervention for those with exocrine insufficiency or endocrine insufficiency. And then a favorite topic at our multidisciplinary pancreas boards is whether we should ever intervene on asymptomatic patients who have a stone that's causing obstruction, which is leading to atrophy upstream, and whether the risks of intervention are worth potential benefits long term. As we'll hear a bit more, there's many mechanisms of endoscopic therapy, which are traditional through ERCP, and as well in ERCP are usually or often combined. So ESWAL is extracorporeal shockwave lithotripsy, and it's the use of shockwaves to fragment the stones. As you can see on the diagrams on the right, there is an electromagnetic coil shockwave generator, a focusing system which helps target the calculi, and a coupling device. And this is usually performed under fluoroscopy or, less so in GI, but it can be done with ultrasound as well. The technology was initially described for kidney stones, and we've adopted it in GI. The shockwaves generate a compressive stress to cause stone fragmentation. A key thought for when we're deciding whether or not to use ESWAL is that we can only really localize the stones for this therapy if they're radio-opaque, which can be challenging if a stone is small or if it's radiolucent. Sometimes the placement of pancreatic stents can help facilitate the targeting of these stones if they are not radio-opaque. For this procedure, patients do require sedation. It can be MAC or general anesthesia. And the number of shock waves applied is variable in the literature, anywhere from 3,000 to 6,000. The diagram on the bottom left is a sort of schematic of the patient on a fluoroscopy bed tilted to the side so that you can better view the stones away from the vertebra with the coupling device. And then the picture above is a real picture from our endoscopy suite taken by one of our fellows for this talk. Thank you. The main patients that are selected usually for ESWAL are patients with radiopaque stones that are 5 millimeters or over and obstructing the main pancreatic duct. Smaller stones are more difficult to visualize, and therefore we are usually using this technology for stones over 5 millimeters. This is especially useful for stones in the head or body. We often avoid the tail, one, because there's less benefit to be gained by relieving duct obstruction in the tail, but also we have a concern that the shockwaves could cause damage to the spleen. As well as often followed by endoscopic extraction of stones or stone fragments, but not always. It is useful to consider a CAT scan, or particularly non-enhanced CAT scan, before embarking on ESWAL. This will help determine the location, size, number, and density of stones. Many of our patients with chronic pancreatitis may have some of their imaging in MRI, but if we're thinking about planning procedures, CT can be particularly useful. And then when we begin embarking on ESWAL, we usually target the stones in the head of the pancreas first. And if we're progressing over multiple sessions, if there's more than one stone, we're going to progress to the tail. And the theory is that we permit the elimination of the stone fragments from the head and then more distally. So in terms of the timing of ERCP after ESWAL, there is data to say that some patients don't even need ERCP for stone extraction. And I think from a historical perspective, it used to be that all of the ESWAL was performed by our colleagues in urology, and so patients rarely had ERCP at the same time as ESWAL. With the advancements where we can now obtain machines to do ESWAL ourselves, there's the thought that we can make it easier for patients and reduce the number of sessions of anesthesia if we perform ERCP right after ESWAL. And I thought this was a very interesting study as we think about how to combine technologies, whether there is a benefit to same session ESWAL and ERCP. And this is a study that said that basically if you do ERCP shortly after as well, it's actually less effective. And the theory was that perhaps there's edema of the pancreatic duct from the shock waves, and that there may be a benefit from waiting and allowing there to be a gap of time between as well and ERCP. Here we can see a stone. Let's see the arrow. No. That is visible just north of the pancreatic duct stent. And this is a decently sized stone that one session of ESWAL, and this is the scout film for the follow-up ERCP to extract stone fragments. And it's a little difficult to see, but there's no stone north of that stent anymore. The complications that we think of for ESWAL include most notably pancreatitis, known as post-ESWAL pancreatitis as opposed to post-ERCP pancreatitis. Other considerations could be hematuria, GI bleeding, skin erythema, a hematoma of the liver, or perforation. Pancreatitis is by far the most common. The others are much rarer. In terms of risk factors for pancreatitis, one study tried to elucidate folks that are more at risk of having a complication. As you can see from the table, the rate of post-ESWAL pancreatitis was about 4%, which is pretty common across the literature in this cohort of people receiving ESWAL. And risk factors for increased risk of complications was seen in those with divisum, perhaps because the smaller duct, they have more intraductal pressure. And then those who had a longer interval between the time of diagnosis and the time of ESWAL treatment. Protective factors were male, gender, diabetes, and already having exocrine insufficiency. So in terms of outcomes, there's a recent large study of over 5,000 patients for large pancreatic duct calculi from India. So this cohort included both radiopaque and radiolucent stones, but most notably, nearly all of the patients were symptomatic. And so radiopaque stones underwent ESWAL, and then they had ERCP for duct clearance. Radiolucent stones had either ERCP with stent placement or nasopancreatic drain placement, then underwent ESWAL with ERCP. In terms of the population in the study, 90% were idiopathic chronic pancreatitis. On the table on the left, you can see that 80% of the stones were radiopaque, and more of the stones were proximal in the head or the body. And in terms of the number of sessions that were required for clearance, the sort of most common number was 3 sessions. And about 72% of patients had complete fragmentation of stones, and nearly 98%, so nearly all of them had ERCP. In this cohort, the complete stone clearance was 73%, and pain relief was notably 82%. And they assessed pain by both pain scores and the use of analgesics. On a meta-analysis recently that does not include this study, this was about 4,000 patients. Similarly, there was 86% of complete stone fragmentation, 70% complete duct clearance, and here we see a decreased efficacy in terms of absence of pain, about 64%, and again, 4% overall risk of pancreatitis. In terms of the risk of persistent pain after ESWAL, this is an interesting study of 640 patients who went both ESWAL and PD stent placement, and they assessed the independent predictors of pain and found that the factors with increased risk of pain after both therapies were an underlying dilation of the main pancreatic duct, duration of symptoms, but especially ongoing use of alcohol and tobacco. And I think this suggests that no matter what therapy we embark on, it's very important that there's a multidisciplinary approach to patients, whether it's surgical, if there's a stricture, or behavioral for things such as alcohol and tobacco. I wanted to show an example of a difficult small stone. As you can see, it's where the arrow is pointing to. It's radiopaque, but it's small in size, and it is right over the spine, so difficult to target with ESWAL. And we underwent 1 ESWAL session for this patient, and unfortunately, there was no improvement. In fact, the stone maybe grew a bit. So I think it shows that it's very difficult to target small stones, and in this patient, we're trying to, place a stent to better localized for the future. And I want to show another example of a difficult large stone. As you can see, this is a very large stone in the head of the pancreas. This patient is a young male who wanted to avoid surgery at all costs. He actually was recommended to have surgery up front given the size of the stone and the upstream duct dilation. He underwent 3 sessions of ESWAL. And as you can see on the follow-up ERCP image, the stone is decreased in size, but it is still persistent. And ultimately, he underwent surgery with good resolution of symptoms. So I think that brings us to the discussion. Will come a little bit later, but I think it is important to always have surgery as an option for patients with pancreatic duct stones, and the discussions of when to embark on endoscopic therapy, whether it's ERCP or ESWAL or surgery, is very important, and it's a multidisciplinary discussion that's important. And then just one recent study that I thought was particularly interesting that shows that however we approach it, clearance of duct obstruction may be valuable not just for pain, but also for diabetes. As you can see on the bottom left, this is a study of folks who underwent ductal intervention of any kind, whether it's ERCP, ESWAL, or surgery. All of them had pain at baseline, but what they were really looking at was diabetes. And I think that in addition to pain, we have to think about the other outcomes for our patients, and there was a significantly diabetes-free interval with any sort of ductal intervention. So while we focus on all of our modalities to treat pain, we should also think of our other outcomes for our patients. Thank you so much.
Thank you, Dr. Khanna. Next, Dr. Samuel Han from Ohio State will present on have new endoscopic treatment for stones and strictures improved outcomes.
Thank you so much for that introduction, and thank you to the AGA and the session moderators and the session organizers for putting this together. It's definitely a pleasure of mine to be talking about my favorite topic, pancreatic endotherapy. This is my disclosure. So today I really like to focus on the latest advances in the management of pancreatic duct stones and strictures in patients with chronic pancreatitis. And then I'd also like to touch on the impact of these therapies on patient-centered outcomes. So as most of you know, pancreatic duct strictures and pancreatic duct stones represent fibrosis-related complications that occur actually quite frequently within the disease course of chronic pancreatitis. So if associated with pain, patients with these complications are often referred for endoscopic treatment, which has largely consisted of ERCP. So we're going to touch on PD strictures first, for which really the goal of treatment has been stricture resolution that consists of typically dilation of the stricture followed by placement of a plastic stent. European guidelines recommend placing a 10 French plastic stent with serial exchanges for up to a year until stricture resolution. However, several plastic stents can be placed to increase the maximum outer diameter of these stents to help stretch the stricture out. And just to provide kind of a graphical or video representation of this, so this is a classic pancreatic duct stricture, diffuse dilated upstream duct. We're going to do a balloon dilation, and when you do the balloon dilation, that's really when you see the severity of the strictures. So on the pancreatogram on the right, you're going to see that that balloon right in the middle of it is a very, very tight stricture. It's not improving with any level of balloon dilation. So this is something that we're going to need to serially upsize in terms of our pancreatic duct stents to be able to treat this stricture. This is just a representation of that patient where we did pancreatoscopy. And I was planning on doing some laser dissection, but basically this is what the stricture looks like beforehand. Very fibrotic, very obviously you can't get the pancreatoscope through. And this is again a placement of a plastic pancreatic duct stent. I wanted to touch base on refractory strictures, which has gained a lot of interest in terms of the metal stent design. So to define refractory strictures, I think they are best described as symptomatic dominant strictures that persist or relapse after 1 year of plastic stent placement. So similar to how we use metal stents in the bile duct, we can use metal stents in the pancreas as well. None of them are FDA approved for this indication, however. And I wanted to draw your attention to this recent international multi-center prospective study that examined the use of a soft metal stent that's exclusively for use in the pancreas. It came in a 6 or 8 millimeter diameter. It had no internal flange, and basically the stents were kept in place for 6 months before they were taken out, unless they had migrated out earlier. And pain, their primary endpoint was pain reduction. And I really wanted to highlight that only a quarter of these patients had either complete or partial pain relief 6 months after stent removal. And actually, there was a very high stent migration rate out as well of the pancreas, so 47.7%. And there was also a relatively high serious adverse event rate, primarily consisting of abdominal pain and post-ERCP pancreatitis. And importantly, as it relates to metal stents, there was a 7.5% rate of forming de novo strictures. So these are stent-associated strictures, typically occurring near the internal flange, and are oftentimes very difficult to treat. So all in all, from this study alone, it doesn't seem very promising to use metal stents. But I want to contrast that to a different type of stent design. So this is the Bonastent M Introducto produced by Standard Zytec. And so this is a stent that has a central saddle. So this saddle actually overlies the stricture, and then the length of the stent is very short. So it's about 1 centimeter for the saddle, 1 centimeter for each end. And so it's meant to be left introductally. So you can see that there's a distal lasso, and on the rightmost picture, you see that the lasso is coming out of the major papilla. That allows for easy stent retrieval. So the theoretical advantages to something like this is that you can help prevent stent migration. You cover as little of the pancreatic duct as possible, so you're trying to prevent occlusion of the side branches, and then you're also preventing duodenal reflux into the pancreas. So this prospective study was a single-arm study, but basically for 3 months they kept the stent in, and then after that they found that stricture resolution was seen in all patients with associated pain relief as well. And then during a median follow-up period of almost 3 years, there were only 2 instances of stricture recurrence. So perhaps a stent like this is a more pancreas-friendly stent. However, this is not currently available in the US. Now I wanted to talk about the concept of pancreatoscopy-guided laser dissection for refractory strictures. So Raj Shah and I conducted a pilot study where we used thulium laser under pancreatoscopy guidance to cut away at refractory strictures. So we did this in 9 patients with refractory strictures all throughout the pancreas, and we found a very high short-term stricture resolution rate. And then during a 1-year follow-up period, we found that there were no stricture recurrences seen. And I want to provide a video demonstration of this as well. So this is the inflamed pancreatic duct with a stricture. This is a pancreatoscope allowing for direct visualization. We're using a thulium laser, and we use a thulium laser because it has a shallower depth of penetration compared to a holmium laser, which is what we typically use for stones. And we're basically dissecting away at the stricture in 4 quadrants. And this allows us to gradually open up that stricture. And where we actually find this most useful is when there's a stone upstream of the stricture that's impacted and we can't get any devices past that. So essentially what we're doing is we cut away at the stricture, and then we're able to use the same laser fiber to also break away the stone and help reduce the number of procedures. And that segues nicely into my next topic, which is pancreatoscopy-guided lithotripsy. So by placing the pancreatoscope into the pancreatic duct, we can directly visualize the stones, and we can use either electrohydraulic lithotripsy, or EHL, or laser lithotripsy, or LL. And we basically fragment the stone into small enough fragments to remove. So case series that are largely retrospective have shown very high stone clearance rates using either EHL or laser lithotripsy. But one of the primary questions remains is, what is actually better for pancreatic duct stones? ESWL, like Dr. Khanna was mentioning, or pancreatoscopy. So we're actually currently conducting a multi-center randomized trial comparing the two head-to-head. And we officially reached our halfway point this month, so hopefully in a couple of years we'll be able to give some updates about this. I wanted to provide some video representations as well of the different types of lithotripsy modalities that you can perform through pancreatoscopy. This is electrohydraulic lithotripsy, or EHL. So it generates an oscillating shock wave of pressure that requires a saline medium for shock wave transmission. These shock waves fragment the stone, as you see here. Again, I would say that this is kind of like you're just kind of shooting energy everywhere, so it's not very precise, but it is most commonly performed in the US. Then I want to show an example of laser lithotripsy, where in this case we're using a holmium laser. So the nice thing about the holmium laser is that, as with all lasers, is that you have a green light that shows you where you're directing your energy specifically. So this, to me, is a little bit more precise. Also, you can generate very high levels of power with this. And so this is an example of laser lithotripsy breaking up a pancreatic duct stone. And then lastly, in terms of pancreatoscopy techniques, this is a stone that was actually refractory to 2 sessions of EHL and 2 sessions of ESWL. Very large stone, very, very dilated duct. And so we're actually going to just try to remove it directly using a SPY basket, which is a cholangiopancreatoscopy specific retrieval basket. So as you can see here, we're positioning the basket and we're trying to delicately maneuver the basket around the stone and capture the stone. So this stone is a little over 1 centimeter in size. The retrieval device is actually designed to capture stones up to 1 centimeter in size. It has a maximum outer diameter of 15 millimeters. As you can see, we're able to grasp it, and then we're able to drag it out. And then this is the endoscopic view, but essentially using a kind of a stone extraction maneuver, we're able to get the stone out, and you can see it's actually quite a large stone that we're able to remove. And then that gets us into the question, so what happens when you fail ERCP and the patient also fails ESWL? So that brings us to the concept of EUS-guided lithotripsy, which this group out of Malaysia demonstrated in a pilot study. But essentially, they're directing a 19-gauge needle under EUS guidance into the pancreatic duct, and through that EUS needle, they're directing a laser lithotripsy fiber to basically fragment the stone. So it's great in a situation where you can't cannulate the pancreatic duct or you can't get the pancreatoscope in a stable enough position to perform typical laser lithotripsy. This is their video that they provided in their case report, but basically this is a dilated PD. The pancreas is very atrophied. They're able to puncture the PD directly with the 19-gauge needle right into the stone, actually. And then through the needle, they're advancing the laser lithotripsy fiber, and then they're basically hoping that the fiber is touching the stone, and they're actually emitting laser waves that way. Now, I'm a little hesitant about something like this in the sense that EUS only provides a 2-dimensional image. Additionally, so you don't really know where the laser waves are going. I also worry about placing a 19-gauge needle into the pancreatic duct and not causing a leak if you're not going to put a pancreatic duct stent in. But certainly a technique that warrants further investigation. Fundamentally, however, I think one of the most important questions is, are we actually improving patient-centered outcomes? So it's great to remove a stone or treat a stricture, but are you actually doing anything for these patients? So this is one of the representative studies that try to get at this question. It's a large multi-center cross-sectional study from the Scandinavian Baltic Pancreatic Club. So essentially 20% of their participants underwent endotherapy. And after undergoing endotherapy, 42% of them had basically no pain whatsoever, and then 42% had partial pain improvement. And then they used the EORTC, which is a cancer-specific quality of life instrument, but they compared those who received endotherapy with those who received medical management alone. And patients who received endotherapy had slightly improved quality of life. And then as part of the Chronic Pancreatitis, Diabetes, and Pancreatic Cancer Consortium, one of the outcomes we really tried to get at was the durability of pancreatic endotherapy. So using the PROCEED data, we looked at 238 patients who received pancreatic endotherapy, and we found that essentially 43.3% of them needed another session of another treatment course of endotherapy after a median duration of 2 years. So again, another aspect to talk with patients before you start embarking on endotherapy. So what do we need in the future? I think one of the greatest needs actually is identifying before starting any endoscopic treatment which patient is going to respond favorably. And this is where a lot of great work is being done by people in this room. So we heard Dr. Phillips talk, and so she's leading a study with Dr. Drews, who's also giving the keynote talk today, using quantitative sensory testing to determine the pain profile of patients to ultimately direct therapies to specific patients. And along those lines, we still need a lot of work in examining how endotherapy affects patient-centered outcomes so that we make sure that we're actually treating the individual patient and not an imaging finding. Thank you so much.
Thank you, Sam. Let's see. Double click.
Oh, no, start. Start. And then click on this line.
All right. Our next speaker is Dr. William Nealon, who's a senior surgeon in the field, who's going to talk to us about chronic pancreatitis surgery, when and what operation.
Thanks so much, and good afternoon, and emphasis on senior. I'm tempted to tell you that I've managed this disease since the very beginning of my career. After my residency in surgery at NYU, I went down to Texas and worked with a man named Jim Thompson. Some of you know his name, but a famous surgeon scientist who worked in gut peptides. And he said I should follow chronic pancreatitis because of the potential it would have on seeing what gut peptide alterations take place during chronic pancreatitis, and I was off and running. Am I going? So the American Board of Surgery, it used to give a terrible exam every 10 years and everybody hated it. So now they give a small exam that's open book every 2 years. It has 20 general questions and 20 specific. So this is one of the questions that last year was on my recertification exam. 72-year-old female non-alcohol abuser has been hospitalized every 6 weeks for the past 3.5 years at various tertiary care centers, famous ones. Each admission is for abdominal pain and nausea. Variably, amylase will be elevated or not, and imaging is as follows. So these are fairly classic changes that we all recognize: a dominant mass in the head of the pancreas. You can see a dilated duct in the mid portion of the pancreas, and some calcification throughout the gland. And then you can see some dilatation in the tail of the pancreas as well. So the question on the certifying exam is, which of these interventions are the right answer for someone trying to get certified in surgery a year ago? So I'm not going to tell you the answer till the end, but these are the choices. So, I see, my next slide is right in front of me. So I apologize for the horrible quality of this, but I was part of an international consensus conference 6 months ago, I guess, that was sponsored by NIDDK, in which extensive international systematic reviews were done on all aspects of pancreatitis, and came up with a publication that which just came out in April of this year in Pancreas. And I'm going to read to you one of the lines in the middle of the manuscript. And I've been worried I'm going to be the spoiler for this conference. There lacks consensus agreement in the field regarding the optimal timing and order of invasive interventions to treat painful chronic pancreatitis. Despite well-conducted randomized studies showing superiority of pain outcomes with surgical drainage compared with endoscopic drainage and early surgery to be favored over later surgery, many clinicians persist with multiple endoscopic procedures before surgical referral. The reasons which were postulated were that perhaps not willing to accept that it failed, lack of surgical experience, expertise, which is a serious problem. I might be the only person in the New York area that knows how to do this operation. And there's a lack of definition of so-called early stage chronic pancreatitis. So I'm going to give you some historical perspective, since I was kind of around when cavemen were there, that the earliest clinical reports made the assumption that the ductal dilatation suggested that the pathological process was predicated upon the high pressures in the ductal system. We've heard everybody mention that today. In view of the fact that there were no valves in the pancreatic duct, two surgeons postulated that simply releasing the pressure via opening the head of the pancreas via the ampulla, that was done by a man named Duboulay in the 1950s, or the tail of the pancreas via a minimal tail resection and anastomosis to the roux-y limb of jejunum, that was proposed by Duval. Both failed and were abandoned. Duboulay specifically performed open pancreatic duct sphincterotomy in the late 50s. Importantly, these studies virtually mirror some of the 4 to 5 decades later when the endoscopic management of chronic pancreatitis emerged with the same end. Here, with the same aim to decompress the pancreatic duct. Here, endoscopic sphincterotomy with or without pancreatic duct stenting was and continues to be evaluated, virtually identical to the measures explored by Duboulay in the 1950s. Perspective of history. Out of this morass, there emerged the Pusto procedure as a modification of the Duval procedure. So he actually included a resection of the tail with drainage of the pancreatic duct. Pusto himself immediately abandoned the portion of it that included tail resection. And finally, there was a surgical procedure that seemed to be successful and had essentially worldwide acceptance. Importantly, it became apparent early and ongoing that a failure to perform the ductotomy deep into the uncinate process led to outcomes failures. In other words, someone just draining the mid-duct of the pancreas got no outcomes, and many of the failures that are seen in the surgical literature are because of that failure. Too often, inexperienced pancreatic surgeons thought it'd be easy to just make a little incision in the mid-body of the pancreas and put a little piece of intestine there. The fact that this inadequate incision led to failures further exemplifies that decompression alone is inadequate. One consequence of these failures has been the common assertion of surgical failures in the reports on endoscopic management. So we already have seen this, that what we see is patients who have recurrent acute attacks, they have abdominal pain, they have endocrine and exocrine insufficiency, and the variously known complications of chronic pancreatitis. In general, we do imaging with either MRI or CT scan. We can do ERCPs, and we get some laboratory studies in general. And so this is a simple, someone mentioned this already, the complexity of this. So pay attention mostly to that right-sided column where all of the different specialists who, in a best case scenario, are involved in all the discussions for these patients, and it's a significant one. Pain medicine and addiction medicine and psychiatry, I will say, are even more important. So the indications for surgery are the pain that's either daily or intermittent, and the intermittent ones often require repeat hospitalizations. And very often, because the pancreas plays a significant role in your nutrition, you can have nutritional deficits, and if you don't take care of the insufficiency states, then patients do much less well. There's a 100-fold increased risk of pancreatic ductal adenocarcinoma and chronic pancreatitis, so you should always have that in the back of your mind. And now hereditary and genetic mutations have to be considered as well. So this is the picture of the Putestow procedure as he first performed it, and you can see the longitudinal incision is very inadequate in his first drawings, but you can see this included a resection of the tail after Duval. And this is Partington Rochelle. Some people feel obligated to give this name because he didn't take out the tail. I think we ought to give Putestow the benefit of the doubt. But at any rate, you can see that the incision is taken along the body of the pancreas, and a long limb of jejunum is placed along the side of it. This now is the picture of the fry, and my interpretation of why we're now seeing much more success with this surgery is that you can't do this operation without getting well into the uncinate process. So they came up with this silly thing. They called it the time keeper of the pancreas, and it's a ridiculous name. What I really think this is about is the fact that you have acceptable opening into the head of the pancreas and drainage. So this is just to show, as that first quote I read you, there's been countless prospective randomized trials about chronic pancreatitis, and this is not one you're going to try to read, but these are all different studies looking at DP PPRs, duodenum preserving pancreatic head resection, which is now called the Baker because it's much easier to say, or the 5 procedure, and all of these are comparisons with pancreatic duodenectomy. The problem we have in America is the vast majority of people who call themselves pancreatic surgeons got there from the surgical oncology fellowship. And what that means is that in 2 years of that fellowship, they have 3 months of pancreatic cancer and 0 months of pancreatitis. Yet I've said for years there should be a course in medical school called I Don't Know, because the truth is they don't know anything about it, and yet you go to them, and instead of telling you, why don't you go to someone who knows, they say there's nothing you can do. But just so you know, multiple prospective randomized trials. There's even an important one, because what they do, they go to the brown shoe store. If you go to the brown shoe store, you get brown shoes. So if you learn how to do a Whipple, everybody who comes with a pancreas problem, they do a Whipple. So this is an important study from years after. They followed up over years to show that the survival and the outcomes after comparing Fry procedure to pancreatic duodenectomy are infinitely worse for pancreatic duodenectomy. In other words, that should never be the answer. So this is a nice paper that was recently reported by Syed Ahmad from Cincinnati, who made most of his name with TPIAT, which is the total pancreatectomy. You're going to hear about that in a minute. But in this case, I'd like to just show that he again shows that the use of Whipples in his large 21-year report is only 16%, and that shows that he actually knows what he's doing, and we're going to hear more about TPIAT in a minute. So in summary, the disease and the patient population of candidates for TPIAT differ significantly, and I'm not going to waste my time with that because you're about to hear about it. So goals of therapy are durable pain control and preservation of pancreatic function. Early surgical management leads to better outcomes, and we've heard about that from a couple of people today. I'll take some credit for the fact that my paper in 1989, when some of you were not born, where I established preservation of function after a drainage procedure, may have been the start of this. Now literature, it's well accepted that you can have preservation of function with these operations. And as I say already, I have a concern that there exists a knowledge gap among American surgeons primarily trained in surgical oncology. So what was the answer of the certification question? Big surprise, was the Fry procedure. Thank you, everybody.
Thank you, Dr. Neelan. It's going to be close here. Okay.
Click on the other stuff first.
All right, our next speaker is Dr. Barbara Kirchner from Stanford University. She's going to be talking to us about TPIAT, patient selection, and outcomes.
Thank you very much, and thank you for the opportunity to present. Let's see. How many? I have to click on this. Okay. Okay, perfect. No disclosures. So I'll briefly mention the rationale for TPIAT. As we heard here, mostly I see my patients who come with intractable pain, and it's a horrific experience that really has multifactorial etiology in pancreatitis. In acute setting, in addition to pain, those patients have a lot of GI side effects. All this leads to multiple hospitalizations, missed school, missed work, unable to make actually life plans. In a chronic setting, though, it also leads to the poor endocrine outcomes as well as exocrine outcomes, and many of those patients have depression, anxiety, and actually high rate of suicide, much higher than other populations. So the management options, of course, medical and endoscopic come first. Then, if that fails, historically drainage and drainage resection procedures have been employed. However, depends on the study. There definitely failure of those procedures in up to 50% of cases. It's not suitable for certain disease such as diffuse small duct chronic pancreatitis or acute recurrent pancreatitis. And if you are considering actually long-term auto-islet transplant eventually, it impairs islet cell yield. So TPIAT is really a Rolls Royce of those for treatment of chronic or acute recurrent pancreatitis, where the pancreas is removed to relieve the patient's pain, and islets are isolated from the pancreas and given back to the patient to minimize the risk of diabetes. So in terms of indications and preoperative considerations, well, the story started, of course, because as everything with surgeons, the competition, because the University of Minnesota was competing with Wisconsin to treat the type 1 diabetes by using the islets. But auto-islet came about because they were trying to figure out how to study islet transplantation without alloimmunity. So this was the first report published by Dr. Sutherland and Dr. Najarian of 10 patients with actually, in 1980, with actually pretty good outcomes. However, now, over the course of the time, chronic pancreatitis, and I'm just putting my colleagues here who actually refer those patients to me, chronic pancreatitis is no longer the only indication, and in fact, those patients have a lower islet yields, probably because of the etiology of the disease, but also recurrent acute pancreatitis, and now more significantly hereditary pancreatitis. As you can see, in a current cohort, up to 80% of kids actually have a hereditary disease who undergo this operation. So other indications have been described. the islet isolation from partial pancreas after the trauma that was given back to the patient, to the child, as well as, this is controversial, not done in the United States, but the Italian study that actually reported giving islets back after the resection of partial pancreas resection for malignant or low malignant potential neoplasms. As you can see, recurrence for malignant cohort is actually 19%, so it's not necessarily something you want to go back and do at your institution. So there is definitely evolution of patients from adults performed, first adult performed in 1977 to now we're offering this operation to very young kids. And this is a fantastic study that was published by Dr. Bell and Dr. Chinakotla, my former colleagues, of kids with primarily genetic risk factors, and at 2 years, 100% discontinuation of narcotics, significant decrease in hospitalizations, as well as discontinuation of insulin following the operation. So there are some preoperative considerations, for example, timing of the surgery. So this is for pediatric population of very young patients. There's an attempt to avoid drainage procedures due to the loss of islets. This is older paper, but it shows that after the Pusteau distal pancreatectomy, islet isolation, if you pursue the completion pancreatectomy, is significantly lower compared to no prior surgery. Also, patients with hereditary pancreatitis, the older the patients and the longer duration of the disease is associated actually with poor graft function after the surgery. So other preoperative considerations, timing. So this is a patient, my patient with severe disease, preoperatively multi-system organ failure, necrotizing pancreatitis, 6 months before surgery. This is his CT scan. As you can see, a number of fluid collections, inflamed head of the pancreas. This is not the time when you want to go and start taking the pancreas out because everything is involved, everything is inflamed, and there can be a lot of complications. This is another case of a gentleman with a significant chronic calcific pancreatitis that actually had significant inflammation of the celiac trunk. And his celiac trunk truly exploded during the pancreatectomy because the vessels were so friable. So he unfortunately received infrarenal jump graft from the aorta to the liver in order to revascularize the liver as well as stomach. So, and then malignancy concerns, as you already heard, since we are operating on a wide range of patients, we do have to be thoughtful of this. This was an intraoperative finding, although I have to say the preoperative CT did not look that normal either, but workup was negative. So the biopsy came back as low neuroendocrine tumor, so islets were not given back to this patient. This is a lot more unfortunate situation where actually patient presented with metastatic adenocarcinoma 1 year post-PIT. The risk factors for this gentleman were he was older, as well as he had unknown cause of the pancreatitis. However, the standard pancreatic cancer markers were actually negative at the time of the evaluation. So in terms of surgical approach and auto-islet transplant, so I grew up performing usually pancreatectomy, duodenectomy, cholecystectomy, and splenectomy. All patients underwent splenic vaccinations preoperatively. Pancreas was sent to the lab on campus. While this was happening, we would reconstruct using the Roux-en-Y reconstruction. That took about and islets would come back in about 4 or 5 hours, and islets were infused into the portal vein directly under the visualization, measuring portal pressures as well as portal flows. The reason that's important because as portal pressures go up, there's increased risk of portal vein thrombosis as well as bleeding postoperatively from all the mesenteric vessels. So, and at the end, most patients got gastric jejunostomy because a number of them had the gastric dysfunction. So this kind of to avoid having an NG tube and also provide them eventually with medications as well as eternal feeds. So I moved to Standard a few years ago, and my partner convinced me that we should change our practice. So currently we try to avoid Roux-en-Y reconstruction as well as try to preserve the spleen. So far we're successful, but we're a very young program, so we'll see what's going to happen in the future. From more larger study of multiple centers, 75% of cases are still done open, 20% laparoscopic hand assist, and only 5 laparoscopic and robotically pure. So it's probably tells you about the treacherous situation and how much inflammation there is and fibrosis in those patients. So the other things that the majority of patients undergo splenectomy, especially kids. Ruined white reconstruction is probably the most common reconstruction in those patients, as well as a number of patients do get those feeding tubes. So, and islet isolation, pancreas is taken to the lab. At that time, pancreas is being trimmed, cannulated for enzymatic ingestion. Then the pancreas actually digested using enzymatic and mechanical digestion using the Ricordi chamber. The purification step is actually not used very commonly for auto islets, and the reason for this, up to 30% of islets are actually lost at the time of the purification, and eventually islets are packaged. So it takes about 4 to 5 hours of highly qualified team. In the era of remote isolation, because now my pancreas flies in a private jet for 4 hours to get isolated, and patients actually go to the floor, and then next they go to the interventional radiology, where under the visualization of ultrasound and fluoro, portal vein is cannulated and islets are infused by, and these are our interventional radiologists who are doing a fantastic job. So the outcomes definitely important it depends on islet quality. It's been shown in the old days that more islets you give, the more likely patients are going to be insulin independent. Over 5,000 islet equivalent per kilogram, usually equal to 70% of insulin independence at 3 years. Islets are lost at the time of the isolation, but they're also getting destroyed at the time of the infusion. So instant blood-mediated inflammatory process is part of the innate immune system that actually destroys islets at the time of the infusion. So we give heparin as well intraoperatively as well as postoperatively to decrease this process. Also, other reasons for islet actually dysfunction is the size of the islets because the larger islets get more hypoxic. Islet function is important. We talked about usually they're infused into the portal vein. However, if you pay attention to the red column, the response of the alpha cells is not as good to the hypoglycemia if the islets were only infused into the liver. If they were infused into 2 sites, the response is by far better. And what are the alternative sites? Usually it's a mental pouch, intraperitoneal or preperitoneal. Bone marrow is just an interesting case report. That's all I'm going to say about this. Early postoperative care. So usually adult patients stay in the hospital for about 11 days, kids a little bit longer. Critical issues, I think, is the multimodality pain management. Those patients come with a severe pain and they have a trust in you that you're not going to fail them after the surgery. So also close monitoring of glucose, because the tight glucose control actually improves long-term outcomes after the islet transplant. This is the perfect outcome of my patient who had disease from a very early age and had inability to complete even schooling. This is her 1 month post-op, 4 months, and this is her completing her nursing degree 2 years. So this is a success, but the reality is that you still have readmissions within the 1 month. For adults, it's up to a quarter of the adults, and indications for reoperation are mostly bleeding and infection, as well as portal vein thrombosis has been reported in up to 10% of cases. Of note, I have to say that this is not complete portal vein thrombosis, so nobody should be freaking out. It's probably more small branches of the portal vein that you see, and that it gets better. So in terms of readmissions, why they come back, GI dysfunction and actually infection is the most common cause. And in terms of quality of life, both adults and kids do very well. Their mental component summary as well as physical component summary improves a lot after the surgery. For pain relief, 75% off narcotics at 10 years, as well as up to 80% report that their pain is better at 10 years. However, the data that's not published by Dr. Bellin yet, but will be, that actually the outcomes are getting better and better. So glycemic control, again, about 20% of them will be long-term insulin independent. Kids do better than adults, especially the young kids. And islet equivalent per kilogram, as well as the young age, are correlated with insulin independence. And lastly, long-term survival. I think this is the paper that was actually published over the past month. And outcomes are significantly improved. Pediatrics, 97, and adults, 83% at 10 years. That's compared to 60 to 70% historically. However, if you look at the causes of death, they're kind of concerning. It's sepsis, intestinal complications, diabetes, and suicide and accidental overdose. So in conclusion, patient population and ability to diagnose the disease evolved over time. It is an acceptable procedure for selected patient population. Open surgery still remains the standard of care, and we do need to pay attention to the comorbidities that contribute to the mortality of those patients. So thank you so much for your attention. I would like to acknowledge my team at Stanford, as well as all of my colleagues, our first patient, and Dr. Sutherland, who actually pioneered operation. Thank you.
Thank you, Dr. Gertner. So this brings us to our last talk for the session. Dr. Esbjørn Drews from Aalborg University Hospital is going to deliver the state-of-the-art lecture where he's going to bring together the discussions by all the previous speakers as to how should I manage chronic pancreatitis in 2024.
Thank you very much, Dheeraj. I'm sorry you will likely be disappointed. And thank you very much, ladies and gentlemen, for coming here. I should say that I'm only the replacement for my very esteemed colleague and good friend Søren Olsen, who couldn't come here because he ruptured his Achilles tendon. So you had to deal with the old professor. Now, I have a few disclosures, as you can see, but first of all, I changed my title because, of course, it's about managed pain. And you can see there are a lot of treatment possibilities in chronic pancreatitis, but to treat pain is the far most interesting one. And the reason for that is that if you look into the complications to chronic pancreatitis, as we published here, pain is the far most complication and also the most bothersome for the patients. So now, before I move on, some of you have seen this, it's very important to understand the pathophysiology of pain in chronic pancreatitis. We know that we have a lot of, I don't know if it works, this one doesn't, but if we have a lot of peripheral factors, as you can see, and we know that they may sensitize the nerves, giving some degree of neuropathy. That will again result in a bombardment of the second-order neurons in the spinal cord, rendering them sensitive. And from that, they respond to much lesser stimuli that are normally not painful. And that again results in a bombardment of the central nervous system with reorganization, neuroplasticity, and sooner or later lack of the normal inhibition that we see, and therefore pain may become independent on the original drive. In other words, you may put a line here, say some of the pain could be central, some of it is peripheral, but how to distinguish, we do not know. So pain is complex, and so is management. And these are the options for pain management, which I'll of course not go through today. Just say that we have to do better rather than having these many patient management possibilities. We have to do it better, and I'll show you why today. So now, first of all, we could target the peripheral drivers, saying, let's look into if we have any low-grade inflammation, could that be decreased, as you see here, and then also decrease the central components, removing them so we have a normal central nervous system. It has been shown in some other diseases when we have peripheral neuropathy for somatic reasons, but it has never been shown in chronic pancreatitis. One way to do that is to use something called Camostat, which is a protease inhibitor, and it has shown a signal in Asian studies where it actually showed to improve pain, and recently by Phil Hart's group, they took it into chronic pancreatitis, and the idea was this protease inhibitor could inhibit trypsin activation and reduce the activation of immune cells, and that would be a nice approach. The problem is that no matter which dose was used, there were no effect at all. At least the effect was very good, but it was the same as placebo. And please note, ladies and gentlemen, there is a huge placebo effect. And this is a problem I'll come back to. So another way in doing that could be to look into the duct obstruction and tissue hypertension, as we heard about from the previous speakers. If we could restore the normal function of the pancreatic duct and remove and diminish the tissue hypertension, it may work. So now we enter endoscopy, S-wall, and surgery. The problem is that we do not have a really good rationale for treatment. You may look at this pancreas, it looks awful, but if you really do experimental study, there is no relationship whatsoever between pain and the parenchymal pressure, the morphology with the duct, or the fibrosis. So we do not have a really rationale for doing what we do. Just because it looks bad, it doesn't have to be bad. On the other hand, we also know, we have some data, was shown also by Anna Phillips, that if we have a temporal worsening, I mean, it's an association. We see a worsening of the images, a worsening of the pain. If they go hand in hand, we may believe that. But how many patients have you seen with that? Not many. So I think a lot of studies have compared endoscopy and surgery like that. And I think this is more or less nonsense. I'm sorry to say that. Because, first of all, it's not the same patients. You compare apples and pears. And secondly, if you remember the study by Phil Hart, you don't know what is the effect of the sham intervention. Because nobody has ever done that. So it could be that all you see, I'm sorry to say, is sham. It's a bit provocative, I know that. I want to be provocative. So now, we did a study, which is not published yet, but it will come in Annals of Internal Medicine in 2 weeks, where we randomized patients to either sham or active endoscopy plus S-wall. For the first time ever. Now, we've done endoscopy for 50 years. Nobody ever thought about, could it be that what we see is not a real effect? And I can't show you the details here because it's not released yet, as I told you, in 2 weeks. But what we did was we took more than 100 patients with painful chronic pancreatitis and obstructive disease. They had epidural. They were subjected to S-wall once or twice, and they have endoscopy, either sham or active, right? So 54 had sham, 52 had active. And do you think there was a difference? Now, for the first time ever done. Well, now I'll show you the SHOPE trial. First of all, placebo group. Look at that. Major effect of doing nothing. That is treatment as usual. That is, they also had analgesics because we couldn't just leave them suffering. But endoscopy was better. At least at 12 weeks. But the drawback was that there were no differences in quality of life. There were no differences in pain after 24 weeks. So we had to do much, much better here. So what about surgery? Now we heard a lot about surgery. The problem is that surgeons always tell us, okay, but this always works, but we cannot make a sham control study, sorry, because of the ethical concerns, not making a big hole in patients' abdomen and so on. And of course, that's understandable. On the other hand, what do we know from other studies with pain? Take, for example, meniscectomy has been done for 80 years with excellent results. But when compared with sham, 0. So it could be that we should be a bit more humble as pancreatic surgeons. And I'm not saying that it doesn't work. I'm not saying that. I'm just saying that I don't know. And we had to do better. And I'll tell you how to do better. We wrote a paper about that. You can read if you want. It was published in God a couple of years ago. But now, if it doesn't work in the periphery, what about the central drivers? Could that be targeted then? And then we are into medical treatment. And we have a variety of medical treatments. This is where they work in the central and peripheral nervous system. And of course, time doesn't allow me to go through this. So we have to move on. But I'll just show you, we and our good colleagues from India that also actually did the SHOPE trial, I forgot to tell you that, have done different studies comparing, for example, placebo and pregabalin. And pregabalin is better than placebo. Nevertheless, it has a few side effects. So the problem is that many of our patients, they cannot tolerate side effects. It may be very good, but they have more side effects than pain, so it actually stops treatment. So we had to do better. And one way to do better is to look into spinal sensitivity. This is a paper we published last year. I will not go through it, this neurophysiology, but we showed that patients with chronic pancreatitis have increased spinal hyperexcitability of the neurons that may explain the pain. So the way you can treat that is to use spinal cord stimulation. I mean, 50,000, ladies and gentlemen, 50,000 spinal cord stimulators are inserted every year on different pain indications. And there are only very, very few randomized controlled trials because previously they could feel the active arm, so it is not a real sham controlled trial. But we did a trial. We took 16 patients with chronic pancreatitis and we used high frequency stimulation that is paresthesia free. So we could actually blind that. It was a crossover study. And what was the results? 0. There was nothing. There was no signal at all. And I can tell you, they're really not happy with me, all these patients living from implanting spinal cord stimulators, because I'm not sure it ever works. So this is thumbs down. So now, I come back to my question, how to manage pain in my chronic pancreatitis patients in 2024. As Anna Phillips also said, we have to do better, we have to identify responders. We have done that previously, for example, with pregabalin, where the rationale was that we use quantitative sensory testing. The pancreas bombards the spinal cord, resulting in a sensitization. And if we stimulate the skin in the convergent area, that is the abdomen, and compare that with skin in another area, we were actually able to predict the response to pregabalin with 85% of a likelihood of 84%. And Anna also showed you that we have recently shown that in a later pilot study that patients with central sensitization, they seems to have a much worse effect of endoscopic treatment. So what about the SHOW trial? Remember again, we had 52 patients that have active treatment. And at baseline, we did some quantitative sensory testing, even though the study was not designed for that. But this is results. They are preliminary, and I know. But what we could do is, just based on pain detection threshold, something we call summation, where we use a pinprick, we used the pain variability, because patients with stable pain, we know already they have a bad outcome, whereas if pain is fluctuating, they have a less mature pain system. And we also used the gender, and doing that, we could predict responders, and that is pain-free patients with nearly 90% likelihood, based on a simple test, whereas the rest of them still have pain after endoscopy. Then we used the same method for those in the sham arm, and it was like flipping a coin. Again, verifying that what we did here was really a valid method. So, what about the future? Well, we have our Pancreatitis, International Pancreatic Pain Consortium, where we have 14 centers throughout the world that actually collect data in order to look into what can baseline assessment be used for, can it predict a response to treatment. One of them, the one I'm leading, is actually doing what we call the advanced study. We assess the pancreatic quantitative sensory testing. We assess the nociception, so to say, but we also use different questionnaires to assess the affective, cognitive, social components of pain, but we also do electrophysiology to assess the networks in the brain and how reorganized the brain is, and we look into the autonomic response to pain altogether. This is rather complex. But we do that, and we have published, and the one protocol is published, the other one is submitted, where we're trying to do that all together. So I think we have some light in the horizon, but we have to go together, all of us, and work on such common projects as I just illustrated to you. So thank you very much for your attention. Okay, thanks.
Thank you. We're going to have all of our distinguished panel come at the front, and if you have any questions, come and ask your questions at the microphones.
Yes, Chris.
What an outstanding session. Thank you all. I was sort of thinking about one aspect is that when we treat patients with pain, some of them respond. In my experience, most of them don't respond fully. They still have some residual pain. And I know you were talking a little bit about what might predict a higher or lower likelihood of response, but I was also thinking, I have lots of patients in my clinic who don't have any pain and they have really ugly pancreas. And I guess the question is, why don't they have pain and everybody else does? What is it about them that's different?
Yes, Bjorn.
Thank you very much for an excellent question, Chris. We know already from other pain disorders that some patients, they develop pain due to central sensitization, others do not. We know patients with actually completely the same also, for example, low back pain, where what you look into is exactly the same. Some develop central pain, some does not. It has to do with gender. It has to do with the degree of catastrophizing to things. It has to do with the social environment. But at the moment, nobody, and not even in pancreatology, but also in the field of pain research, can really predict who are responders and who are not. So in reality, I can't tell you, but you and I know when we see a patient the first time without pain, we actually are able to have an idea of who will develop pain over time. And some of these, some of these things that actually you don't understand, it has to be unraveled better. That's what we're doing.
So Hill.
Great, really enjoyable talks. My question is, there are in the pain field many other types of modalities which may be as good as sham, but I thought I'd ask about some of them. One of them is percutaneous electrical nerve stimulation, which is very popular, for example, for GI tract. Has that been used? And a related question is about whether there are biomarkers during the acute phases of early pancreatitis that in any way predict pain for chronic pancreatitis progression.
Okay,
Anyway.
thank you very much for these questions. I'll take them one by one. The first one was, the last one was about if acute pancreatitis can predict, if any features in acute pancreatitis can predict chronification. And we believe actually, because we see sometimes that if you look into the skin only, that a lot of them are very sensitized there. And we know from surgery, post-surgical studies, that if you see a change in the skin pattern, the pain there, especially if it spreads, it seems to predict who will get persistent post-operative pain. But we don't know for sure with pancreatitis. But that may be something we could look into. We also know that opioid use, the frequency of recurrent attacks and so on also seems to predict who will get chronic pain. And now your first question was?
It was about the percutaneous nerve stimulation.
Oh yeah, very good question. We did studies showing that there is a strong effect of acupuncture on chronic pancreatitis. That was actually a randomized, single-blinded study. So there is an effect of some of these complementary treatment, so to say. Another study was published just last year where they looked into pancreas cancer pain that likely has very much the same pathophysiology, and it was shown that transcutaneous electrical nerve stimulation also has a very good effect on these patients. So I can't see why it shouldn't have in chronic pancreatitis, but there are not any studies out there actually yet.
Maybe I could quickly make one quick comment. You may know that the studies on the opioid epidemic in America, maybe across the planet, they claim that surgeons have their fingerprints all over that, and that many times that's been only one episode of a surgery, so that you don't need to have multiple even episodes of chronic pancreatitis that now you're narcotic addicted. And so I think addiction medicine really has to play a role, and how much of this is actual physiologic pain and how much of this is addiction.
think I'd like to just make one additional comment, which is that the field of biomarkers in pain is still very much a nascent one. There's, very interesting data that has come out looking at associations of biomarkers with certain patterns of pain, including neuropathic pain and nociceptive pain from the CPDPC Chronic Pancreatitis Consortium. And so I would say that gives us an early idea of what sorts of patterns we can associate biomarkers with. However, it's still too early to say whether there's something specific that can be predictive. And so I think we'll look forward to some longitudinal data in coming years about that.
And I just want to add, as we've mentioned before, let's not forget that smoking and alcohol cessation are extremely important and really will help and impact patients' well-being. So that's something that as gastroenterologists is really our role to do this in clinic, convince them to stop.
So I have a question for Dr. Khanna. Dr. Khanna, SWOL is used very commonly in Asia as well as Europe. Could you comment on why there has been challenges in adoption of SWOL in the US and what could be done to improve on that?
Well, I think that one of the challenges is just availability and expertise. Most or many centers in the U.S. rely on their urology colleagues who treat kidney stones to do as well because they don't have lithotripsy themselves. One thing that we do at NYU is we actually rent the machine from the same company that our nephrology colleagues do. So when they're not using it, we can, and we bring it to our suite ourselves, and that allows greater access. I think from an education perspective, the technologists who work with the company have most of the expertise that's needed. Our job is to really target the stone and help guide how many shocks to give and sort of assess the pre-ESWAL film and the post-ESWAL film and make clinical decisions about whether or not we're going to do more sessions, whether we're going to do imaging, whether we're going to do an ERCP. So I think it's really the access to the machine that's the greatest barrier. For folks who have a panel of patients with chronic pancreatitis, I think it's great to investigate if your hospital can do something similar and you can offer it.
Excellent talks. I wanted to sort of follow up a little bit more on sham. Is it true that the sham response is greatest in those patients who have the most severe pain and who are undergoing the most invasive intervention? I know this has come up as a topic. Of course, there are a lot of studies that are being done in the placebo space to figure out who placebo responders are before they're randomized in a trial. I don't think a similar effort has been undertaken in sham, but just wanted to get some of your thoughts on that, Dr. Drews.
Okay, thank you very much, Vic, for that question. The thing is that for the CHOKE trial, we haven't looked into that yet, but we'll definitely do that. In other kind of studies, looking into sham and invasive therapies, there seems to be that some patients, as I said, with a high degree of catastrophizing, but also responding with a high sympathetic response to external stimuli and so on, they also have a much higher sham response. The thing here is that if you look into Phil Hart's trial and our trial, we saw a long-lasting sham response, which is unusual. I mean, we speak about 3 months at least. And why that is, I don't understand, because normally we see it goes up again, right? So maybe you're also looking into the natural history of the disease, and maybe we should not only look into call it sham, but rather say, okay, what is the natural history and how does that perform and what do we give them and so on. But it's true that's something we have to look into, and maybe you can utilize it as clinicians. Say, okay, we can use the sham response. We don't care if they get better, it's going to get better, and then we could do something. But we should just be very, very careful with what we do. And like everything, I mean, if I do a study with medication, analgesics, I mean, nobody could approve that without giving a placebo-controlled study, and a large one, right? But for invasive procedures, we can do everything. And this, I think, is a problem we have to face and a problem we have to do better.
Yeah, I'm wondering if sham effect is stronger than placebo effect or if they're the same.
In the CHOKE trial, I mean, okay. The problem is that if you look into Phil Hart's trial, just to give you an example, I mean, sham response was approximately the same as in our study. So we always believed that for invasive procedures, you do anything. I mean, that gives a higher sham response. It has also been shown to be up to 60%, whereas in other studies in pancreatology with medical treatment, normally it's 25%. But here we couldn't. I mean, the two most recent studies, we couldn't actually see a difference. So maybe these patients are different. as compared to other kinds of patients. And that we have to consider because these very large sham response are normally not seen otherwise in other diseases that causes pain.
So this was actually Chris brought up, and in clinical practice, clinicians who see these patients on a very regular basis, they have a good sense when they are making decisions for treatment in terms of which patient is going to benefit or not. So maybe we can go around with the panelists in terms of when we are thinking about these trials for pain, what should we consider in terms of patient selection, and how does that impact the results of some of the pain trials that we see? So maybe we can start with Anna, then we can go around.
So the question is as to the most important factor in terms of patient selection for invasive procedure.
For treatment trials for pain, yeah.
For treatment trials. I think the risk-benefit assessment for me has to do with the impact on the patient's quality of life and their understanding of what is at stake. I think also an assessment of their initial response to medical management for me helps me determine whether it's appropriate to refer them.
And being a surgeon, I'm actually thinking more about also a psychological assessment of the patients and their response to treatment, because sometimes it's more other factors that actually kind of impact their response and their report of their pain rather than the physical pain that they have.
So Varvara and I, being both surgeons, agree completely. What I can tell you is I have no optimism if I see someone who is significantly depressed. If you can tell that that's going to be there no matter what else you do, endogenous depression, zero success in my experience in those sets.
We previously looked into that, and we know that patients that have constant pain, patients with long pain duration, patients receiving opioids, patients also that have multiple procedures previously and other risk factors are prone not to respond to treatment. What I see is that you have two possibilities. Either in such a trial, you could do enriched enrollment, ending up with a very, very selected little patient population. But is that clinically relevant? The other one is to use, okay, we take everything included in the trial, not everything, but we try not to make it too restrictive. And then we have a trial that can easily be, used clinically afterwards. So I think it's a difficult question. The first one must be, if we want to unravel the pathophysiology and so on, the second one is the real clinical practice.
I think just to add that the duration of disease, in addition to all the other psychosocial factors, makes a big difference.
All right.
I have a question about the spinal stimulators. I know that you had the, intensities not high enough to cause paresthesia, so the patients couldn't tell whether they're in sham or stimulator. But do you think the intensities were high enough to drive plastic change in the neurons?
Mm-hmm. That's a good question, and all the people I know implanting spinal cord stimulators, they always claim that it's because you didn't do it well. I mean, the thing is that I can't exclude that other, normally burst stimulation or low frequency stimulation or the other stimulation parameters, they may be effective. The problem is just that then you can't do a sham control trial. We used high frequency stimulation because they couldn't feel that. And it is actually state of the art at the moment. And there is another trial looking into low back pain, much larger trial from Norway, where they also use high frequency stimulation and they didn't find any differences either. So of course I cannot say that all different kinds of stimulation modalities will not work, but I just think we should be really careful before we start doing something where we do not have any evidence. At least this is not the way we work.
Thank you so much for your attention. This was such a wonderful, stimulating conversation to help our patients that are suffering so much. So thank you to the panel. Thank you to everybody. Great questions. Before you leave, panel, would like to take a